I'd like to now introduce Kelly Saldana, the Director of the Office of Health Systems at USAID. Kelly has over 15 years of experience in public health administration and international development, having served in a variety of roles within USAID, including most recently the Deputy Director of the Office of Infectious Disease and previously with the Bureau of Latin America and the Caribbean. She has led a wide array of health programs throughout her career, including the Haiti earthquake response and most recently USAID Zika response. She also developed the agency's approach for the Acting on the Call report, which was published annually the past 4 years to demonstrate work being done by USAID and its partners to end preventable child and maternal deaths. So, with Kelly.
Great, thank you so much. So raise your hand if you are here today for a resilience meeting. All right, raise your hand if you are here today for a health systems meeting. Half and half. What about both? Who raised their hand twice? Not bad. If you're neither, you're probably not in the right place. But I think this is an important topic for us. I think, ever since I took on this role as the head of the Office of Health Systems, it's been a constant question. What do we really mean by resilient health systems? How do we make them happen? Is it just a fancy buzzword, or is there really something different that we should be doing? And we've been doing a lot of thinking about it. I don't think we have all of the answers. That's the whole point of today, is to help us figure out what does it mean to create resilient health systems? What does that term mean? What do we do? Are we doing anything different than what we are doing already? What else is needed? Before I go on, I just want to acknowledge you've all met Liz. Liz Lugton has put in a ton of work into making today happen. And Anwar Akil, who really should be giving this presentation, who has read all the literature on health systems and health systems resilience, and really part of the brains behind today as well. So as we know, this concept of resilience has really sort of come out most recently from the Ebola crisis and other large, unexpected health systems-related crises in the world. It gave us the Global Health Security Agenda, which is about preventing, detecting, and responding to infectious disease threats. But if we look throughout the resilience literature, these terms come up over and over, not just in the context of infectious diseases. Resilience is about detecting, absorbing, responding, recovering, adapting, and transforming. These are all the buzzwords associated with resilience, and really, from a systems perspective, the ultimate goal is to be able to sustain the performance of a health system, both the public health system as well as the curative health system, when there's a shock or a major event. Of course, sustaining performance is difficult on a day-to-day basis, right? It's not just when there's some major activity happening. We want systems to be able to sustain their performance on a regular basis, and we know that that's not always easy. There's lots of reasons within the field of health systems that I'm sure everyone can point to that help or impede a health system's ability to sustain good performance. And it's important that we acknowledge and think about these as well when we're talking about health systems and systems resilience. So when we look at it, again, when we look at this concept of sustaining performance, what do we want to happen? Well, I think both on the day-to-day and also on the major event, what we want to see happen is a system's ability to detect changes in disease patterns, whether that's major or minor. If I'm a district health officer, I still want to know if one community is having an outbreak of dysentery and another community is not. This may not be a major disease of public health importance, but it should be a reason that I might want to shift resources to that community. We want to know if they're just performing differently. Are immunization rates significantly higher or significantly lower in one community or another? And what can we do about that? And then we want to make sure that we've set up the conditions whereby our health workforce can show up to work on a regular basis. And if they can't, that there's some other way, or some, as Alma was saying, some other facility or group of workers who can help fulfill those gaps. So there's a lot of similarities between what we want to do in the event that there's an unexpected crisis that are very similar to what we want to do on a day-to-day basis. So does that mean resilient health systems and strong health systems are the same thing? I think you can't be resilient if you're not strong. That's certainly true, and as we note, the resilient literature is increasingly including this concept of the expected crisis as well as the unexpected crisis. What I'm not sure about is whether or not a strong health system is necessarily resilient. Resilience seems to be sort of an emergent characteristic that comes out when a health system is strong, but we're not really sure exactly what it is that makes that system both resilient and strong. In the Office of Health Systems, we're doing a lot of systems thinking and sort of trying to, as we call it, move beyond the building blocks and to talk about how it's really the interactions amongst health systems building blocks that work to create strong health systems. And I think in the resilience context, it's really understanding also those interactions between demand-side pressures, supply-side pressures, and contextual pressures, and how they all work together to hopefully get resilience to emerge out of our efforts to strengthen health systems. So thinking about this a little bit in more detail, we all know what it looks like when there's a supply-side problem with the health system. It looks like children not receiving their needed vaccines or their antibiotics or their anti-malarials. It looks like women not being able to receive skilled birth attendants when they go into labor. Or it looks like people just not accessing care because they're afraid of the way they're going to be treated by the health provider. We know this. I think a lot of times we work to address these specific symptoms. In health systems, what we've tried to do is really look at some of the underlying causes for those symptoms. So maybe the reason that children aren't getting vaccines is because policymakers have prioritized something else, or the finance or the budget didn't have enough room left to move the resources for that. Maybe the reason there's no skilled birth attendants is there's just too high of a workload on the existing staff and they can't cover everything. Or perhaps district health officers don't have the resources to shift things around. So we could address the symptoms, we could address sort of these more root causes, but again, that's still just the supply side factor. There's also demand side pressures that we know. We look at, again, symptoms from a demand side. We can see a patient not adhering to their medication, which we know has all sorts of implications for drug resistance, or people just not knowing when and where to seek care for their conditions. And that there's just no accountability or oversight between communities and health systems. So again, on the demand side, we know what it looks like when there's a problem. And from a system side, we can think about what some of those underlying causes might be. Culture and religious attitudes, lack of knowledge or motivation to know when to seek care, or just not robust enough incorporation of communities into the concept of health systems. So again, we can address the symptoms, we can address the underlying problems from a demand perspective, but that's only one side of that triangle. There's also contextual issues, some of which are sort of more obvious and specific to the health system, and some of which are a little bit more removed, but nonetheless have an impact on how care is delivered and how people receive care. So we know across the board health systems, there's low investment in the health sector, there's health disparities due to a variety of factors. Food insecurity certainly relates to overall resilience and the ability of a health system to be resilient, as do water sanitation services and their access to that, not only in the community, but also in the health facilities themselves. A little bit farther away is just poor overall infrastructure in countries, the overall economic conditions, inadequate educational services, and increasingly extreme weather events. I bet 80% of those pink Post-its over there are extreme weather events, and you'll note the increasing concentration of them just as we move through the timeline, and that's without my even having studied them. I'm just going to posit that that's what's out there. So again, when we look at what we want to do to get sort of resilience to emerge out of health systems, we know that we want to look at the intersections between supply, demand, and context. This may mean that we wind up working only on the supply side. When we talk about systems thinking in health systems, sometimes people get overwhelmed by the magnitude of it, right? If you go back to this slide, you say, well, what am I going to do about extreme weather? So, you know, I can't handle all of this. But really, I think what we're trying to promote is that if you look at all of these different pieces from multiple perspectives, you will begin to identify things that you can have a manageable interest over and those that you can't. But it is important to look across all three, not only when we're designing programs, but also when we're implementing programs and monitoring them, so that we're looking at what is the impact of something that I'm trying to do. Is it having its intended impact? If I'm working in the supply space, is it having an impact on some of the demand factors? And can I help capitalize on that, leverage that, or do I need to mitigate against it? So this is really the what. I think this is where we've come with health systems, is trying to sort of understand what we need to do in order to make health systems strong. But equally important is understanding, is what we're doing and these interactions enough to make that resilience emerge? And we're not sure it is. We appreciate sort of the conversations today and hearing from you all on what does it take to make resilience emerge. One of our hypotheses is it's not just what we do, but how we do it. So it's not just a matter of looking at demand, supply, and context, but also as we implement those programs, are we building capacity? Are we ensuring that the institutions and organizations that we're working with in countries are able to adapt and transform on their own? Do they have the capacity to coordinate and partner across different system levels? When we work with citizens and staff and individuals, are we giving them agency and autonomy to advocate on behalf of themselves? I think the example Alma gave earlier about those health workers in the Democratic Republic of Congo. There's another DR in my mind from my Latin America days, but you know, those health workers have something within them that helps them to be resilient, and it's capitalizing on that to make an overall system resilient. And then as we implement our programs, are we encouraging this look at constantly adapting and iterating and improving so that really we're working across how and then how we work to really get that resilience to emerge. I think Alma noted, and I would be remiss if I didn't, that this is very much in line with the USAID's approach to self-reliance. I think the local solutions framework that USAID has put out, the 5 R's framework, really is USAID's approach to systems thinking, but to do this and look at from various perspectives by analyzing the rules of governance, roles of stakeholders, relationships both in and outside the system, and then the alignment of resources and or the generation of resources. By looking across and considering these 5 R's, we think that that really will lead to better results, country commitment, and capacity to self-regulate and improve performance. Again, I think from my perspective, it's less important what tools we use, whether we're using the 5 R's framework or we're using other root cause analyses or other systems thinking methodologies. What's more important is, are we considering the various perspectives? Have we looked at, from some way, shape, or form, supply issues, demand issues, and context issues to really identify how we want to move forward? And then as we implement, are we thinking about what we need to do and how to do that so we're really building those capacities? So to give an example from work out of the Office of Health Systems in supporting our missions, in Nigeria, you can look and see that the northern regions in Nigeria have much lower skilled birth attendance than the southern region. So 67% of deliveries versus 16% of deliveries. And if you break that down and analyze it from all three perspectives, you see that on the context side, there's also much more poverty in the north. On the supply side, there's lower availability of both kinds of cadres of key health workers, the community health workers as well as skilled birth attendants. And then on the demand side, there's higher incidence of needing to seek permission or not wanting to go alone for care. So really you can start to understand why that 16% is occurring in the north when you look at all three factors. But what do we do about that? So in our work with the mission in Nigeria, we've recommended, again, sort of thinking about how we do this. We want to build capacity, both adaptive and transformative. So maybe that is about task shifting and sharing of activities between the two cadres of health workers. But also thinking about, can we get girls from these communities trained to be the health workers? And can that help to transform the capacity, not only to have more health workers, but also to build some of those, or to address some of those demand side factors? And what about the capacity to coordinate? And again, this is both with the local organizations we work with, but also within USAID. We have programs through the Office of Transition Initiatives and other work where we can really take advantage of synergies and work that they're doing in a more deliberate way to really get at all these different perspectives. We want to empower. So we also, at the same time, want to look at, are there other things we can be doing to improve women's autonomy, strengthen civil society or accountability, really bring communities in as part of the solution to the problem is fully linked to the health system. And then improved. Are there means by which we can look at data and iterate and adapt at the same time? So I think all of these, none of these are particularly revolutionary or new, but what they are is, I think, again, pulling together all the different perspectives into one comprehensive approach to really sort of get that resilience to emerge. I have a couple other examples from similar work in Pakistan, whereas I'm sure people are aware there's a lot of issues with violent extremism that affect the ability to deliver services all over the country. And really what we've recommended is on building both adaptive and transformative capacity, that they use performance dashboards related to health information systems to promote that adaptive management amongst managers and leaders within the health system, but that we also collaborate with our CDC partners and our OTI partners who do surveillance, and can they also include as part of their overall surveillance linkages to tracking violent extremism incidents so that we know when they're occurring and where they're occurring. And on the empowerment side, really looking at changing social norms on early marriage and domestic violence that's associated with that as part of the full continuum of violence, and understanding what are the health risks of violent extremism, how can we better communicate through the community, through medical associations, through involving youth about some of these risks and their relationships to the health system. And then finally, an example from Indonesia, where we're really looking to sort of roll out universal health coverage and roll out full approaches to strengthening the health system, but also on a more regular basis, but also looking, again, can we build transformative and adaptive capacity? Can we take a total market approach to looking at both the public and private sector, I think as Alma noted, and what their various roles are to influence maternal and newborn services, and how can they work together? On an adaptive side, how can we co-finance local solutions, really bring in the resources that are available locally, and using communities to help identify and target to populations? And then on empowering, can we use media to help us advocate for overall inclusion in the universal health coverage scheme and parts of the health system? So within the Office of Health Systems, we're trying to pull all of this together. We've spent a lot of time thinking on how can we focus on the outcomes we're trying to achieve. So we are not trying to achieve, I hate to burst people's bubbles, but we're not trying to achieve improved governance. We think improved governance is important to achieving health outcomes, but we need to focus on what are those outcomes. In a health system sense, we think those outcomes are resource optimization, equity, and quality of healthcare. I think I've mentioned several times we're really trying to increase the application of systems thinking across the portfolio and in all stages of the program. We want to integrate across building blocks, across those demand, supply, and context variables. We want to increase domestic resources in a broad sense, increase multi-sectoral linkages, build existing local capacity, and work with communities and with organizations to really have them be part of the solution. And it's really so they own it, they can adapt it, and we're building that transformative capacity. There's a couple other things that we think need to be done that we, quite frankly, haven't fully been able to realize, and we think need to be more explicit. And this is on the how side. When we're training managers or we're working with communities, are we also empowering managers and leaders to take responsibility for the work and the decisions that they make, to take an attitude of how do we learn from mistakes rather than punishing subordinates for mistakes? How can we view the processes that we're trying to do as the way in which we continually improve as opposed to we've instituted this new process and now we're done? So really, how can we work with the people we're working with in a much more explicit way to move them on the same path that I think we've gone on to really move from thinking in a siloed way to thinking in a much more integrated way? And then also, how can we also improve the motivation of the workers that we're working with to really believe in their organizational goals and to benchmark against others within their community and sort of create those atmospheres of trying to strive for the best. So for today, as I said at the beginning, we really want to delve into all of these questions further. I am just a vehicle for setting the stage for what the literature is saying and where we think we want to frame this discussion, but we really want to hear from you. How do the unexpected crises influence policy and programming to build health systems? And how can we learn from that to regularly strengthen health systems to be more resilient? And then what can we learn from country-specific experiences about building systems resilience to really get that emergent characteristics and have health systems emerge? So as we go through the day, we'll be wanting to listen for the strategies that you use to build and strengthen linkages between communities, health systems, and then other sectors. What you think the donor role should be in setting the agenda for resilient health systems and how we really get resilience to emerge from our efforts to strengthen health systems. What methods and approaches for assessing and monitoring health system resilience do you use, are most useful, can we bring into this? And then just how can we learn from each other and adapt those learnings into our work. So we're really excited for today. Like I said, it's been a year or so in the making and 2 years since we've been asking this question, and we're really very excited to sort of have this conversation and really collectively come together with what does it take to make health systems resilient. Thank you.